So on behalf of the Asia Diabetes Foundation, I would like to welcome all of you to our annual Diabetes Preventing the Preventable Forum. This year we have arranged a program which is extremely rich in content. We talked about what are the best diets for people with diabetes or at risk for diabetes, the latest developments in microbiota and how to motivate behavioral changes. We also talk about some of the latest medications for the prevention of diabetes, treatment of obesity, as well as its complications. We'll revisit some of the topics regarding how to redefine diabetes and how to reclassify diabetes. And finally, we will also be talking about the strategies to cause diabetes remissions and what are some of the special needs in men and women and also in young people who have diabetes or at risk of having diabetes.
People often accuse carbohydrates of being bad, so they even go on like a low-carb diet or even skipping carbohydrates altogether. So in my talk, I'm gonna lay out evidence regarding different dietary patterns on diabetic preventions. So namely, low GI diet, low glycemic index diet, DASH diet, Mediterranean diet, another diet called alternative health index diet, as well as a low carbohydrates diet.
My talk is really about the role of microbiota and its therapy on managing diabetes patients. So recent trials have shown that there are significant effects of using microbiome therapy on diabetes patients in terms of controlling their metabolic parameters. In the future, I think we should target on individualizing care for diabetes patients by using different microbiome formula to improve their metabolic health.
The topic of my presentation is how to promote behavior change. So in my presentations, I first talk about the importance of behavioral modifications for DM patients. Then I also talk about the prominent theories that has been used to understand behavior change for DM patients. And I also shared an important concept called behavioral change techniques that could be applied into interventions to make the behavioral interventions more effective. So hopefully by making use of these behavioral change techniques, we can improve the effectiveness of the behavioral interventions to promote better behavior uptake of the patients.
SGLT2 inhibitors were initially introduced as a diabetes drug for lowering of glucose level. But since the publication of various cardiovascular outcome trials, people have expanded their interest in looking into whether SGLT2 inhibitor have actually additional cardiovascular or renal benefits. So later on, there has been a lot of large, well-powered, randomized control trials that has been able to show that SGLT2 inhibitor can reduce heart failure and also reduce chronic kidney disease progression. And these findings have therefore transformed a lot of the clinical management guidelines in terms of diabetes management, in terms of heart failure management, and also chronic kidney diseases.
SGLT2 inhibitor has transformed the treatment landscape of management of CKD patients. Finerenone is a novel non-steroidal MRA which exhibits potent anti-inflammatory and also anti-fibrotic activities. Recent RCTs, including Fidelio-DKD and Figaro-DKD, suggest that finerenone significantly reduced the cardiovascular events and slowed down kidney progressions in CKD patients with type 2 diabetes. Where there is actually ongoing study on these two studies, and actually there's a combination therapy may be even more promising due to the complementary effect of these two drugs and also reduction of hyperkalemia using combination therapy. And we are eagerly awaiting further confirmation RCT on these settings.
Both diabetes and obesity are two very important health conditions globally. So the World Obesity Federation predicted that by 2035, 1 in 2 will be either overweight or obese, and 1 in 4 will be living with obesity. Similar increasing trends is also noted in the context of diabetes. So we have to find new ways to combat diabetes. The available agent now is the GLP receptor agonist, which help to improve glycemic control as well as for chronic weight management. But we are excited to know that there are new upcoming agents available, which include the 2G agonists, which comprises GLP-1 and glucagon receptor agonists, as well as GLP-1 GIP co-agonists. Also, we have some phase 2 data from the triple agonists, which involve agonism of GLP-1, GIP, as well as the glucagon receptors. So while waiting these new drugs to be available, let's look at all the data from clinical trials which showed very potent body weight reduction as well as glycemic control. So hopefully we have these new agents available, and that will benefit all patients globally with diabetes, with obesity, to prevent them from developing obesity-related complications, especially cardio, kidney, and metabolic health.
For today, I'll be discussing the definitions of diabetes and pre-diabetes. I'll be presenting a historical perspective on how we initially defined diabetes based on glucose levels above which microvascular complications occur. But since A1C has become available, it seems to more convenient test, but it does have a drawback in trying to detect maybe very early glycemic abnormalities. So apart from revisiting some of the traditional definitions, I will also discuss use of 1 hour post-low glucose and maybe CGM in the future, and helping to pick up diabetes and pre-diabetes.
My topic today is to talk about the different types of diabetes. While traditionally we think of diabetes as a disease that's divided into type 1 and type 2 diabetes, the latest advances actually inform us on a lot of heterogeneity within diabetes, and I'll be discussing this and how this can be useful in guiding future treatment for more personalized treatment towards precision medicine in diabetes.
It's my pleasure and honor to talk about diabetes remission. Is it achievable in real-world practice? Type 2 diabetes is a prevalent condition and is also a progressive disease. Carrying the label of a diabetic patient is really not an easy thing, and diabetes remission is a dream. And here, I would like to cover evidence from clinical trial as well as real-world data regarding different approach, including dietary approach, drug therapy, as well as metabolic or bariatric surgery to achieve the goal of diabetes remission.
The topic I presented today was the relationship between testosterone and cardiometabolic health in men. It is a difficult task because there are a lot of controversies about the results of different trials. It will be difficult to perform these kind of trials because of the heterogeneity in terms of the subjects. Anyway, up till now, the data suggests that treating hypogonadal men with testosterone will improve slightly the biomarkers in terms of cardiovascular risk, and there are still no definite contraindication in treating patients with hypogonadal men with testosterone.
My talk is focusing on pregnancy care, the concept of first 1,000 days of life in determining the future of DM risks. My thought is to start intervention early in the first 1,000 days. The best time is the starting line, which is in the preconception stage.
So in my lecture, I have highlighted the health burden associated with young onset diabetes, the complex etiologies, and also the multiple needs of people with young onset diabetes. I've also shared some of the results of our PRISM study, and also I have given an introduction regarding our territory-wide precision prevention program on young onset diabetes. So I hope you have enjoyed the program, and that I will see you next year again.